weeks, right after mom's had that. Mom's bodies are trying to go back to normal and return their reproductive organs to their pre-pregnancy state. We want to make sure that we're checking, obviously, the uterus after birth. You should no longer be able to palpate it within 2 weeks after the childbirth. So if mom's coming for her follow-ups, shouldn't be something that we could palpate. And again, just a picture for those who have not done a fundal check. Again, you're using, I always was taught like your pinky side, but again, to guard, some women you'll see will use their thumb and their pointer finger to kind of guard, and then using again the other hand to check the position of the uterus height is. Their discharge, again, if they are breastfeeding, sometimes that can cause even more of the hormone to release. That's going to contract their uterus. So sometimes they may say to you, when I start to feed the baby, my my belly hurts or something like that. So again, we look at this. Our worry is for postpartum hemorrhage. So we want them to tell us how much they're bleeding, right? So this would be like an example of a saturation of a pad, right? But if it looks like this, that's not a saturation, right? And I told you guys the story of the mom that said, oh, I'm bleeding through, and then it was like picture number 2 there. So again, looking at that. It changes in color. It goes from that on the left-hand side, like kind of like a darker red, they call it rubra, to serosa, which is like a pink brown that you kind of see in the middle, all the way to the right, a yellow-white, and they'll have that slowly transition over a couple days. So the first couple days it'll be rubra, then serosa, then alba, and they can even have alba for up to like a month afterwards. So. Their cervix will never return to its normal pre-pregnancy state, not that anyone's examining their cervix afterward, but that internal Oz will have a fish, they call it a fish face slit. So it's no longer circular, but more of like a slit, right? And about a week after birth, it'll be only dilated about 1 centimeter. Always look at your incisions. I always recommend the acronym REDA. So you're looking for redness, edema, ecchymosis, discharge, and approximation. Again, making sure that they, you notify if you see anything abnormal. If they have episiotomies or if they tore, again, ice packs to that perineum will help during that time period to help heal. Sometimes it can take as long as 4 to 6 months for that episiotomy to fully, completely heal. Again, it depends on that degree of that there. They may experience hemorrhoids, again, common within the first 6 weeks after childbirth. We want to encourage them to perform Kegel exercises to encourage healing. Again, monitoring their temperature, we're worried about signs of infection, and we want to make sure that uterus is still firm. Again, their abdominals start to go back to their pre-pregnant state. Again, it takes weeks, right? They don't just pop out the baby and look like they did before, right? But some moms can have diastasis, again, that abdominal muscle separation. If it usually resolves on its own. If it doesn't, they may require surgical repair of it. They're going to have a lot of diuresis right after, again, trying to get rid of that excess fluid that they've had. And again, we're making sure that they're emptying their bladder, again, trying to prevent that postpartum hemorrhage by having the full bladder and displacing that uterus. They may need to take stool softeners, so Polase is a great one that we give to help. Again, those especially with a 3rd or a 4th degree tear, those that are on opioids will definitely want to have that. Normal bowel function returns in a couple days, so as long as they're passing gas, they can still go home. But again, sometimes they want to have it before they go. If they're breastfeeding, we want to encourage them to drink an adequate amount of fluids. We want to make sure that we talk to them about how their milk is going to transition. So you can see the milk usually comes in those first few days. They'll start to have colostrum immediately and get Sometimes it's drops, just enough to put in a Q-tip, and then sometimes, again, it depends on if they were multi-paras, you know, that they could have more their milk comes in usually a little easier. If they complain of nipple soreness, again, reaffirming that they're using the correct positioning. Again, their ears, shoulders, and hips should be all aligned when mom is holding. The baby should be stomach to stomach against mom. We want to have mom looking and inspecting her breasts, looking for signs of mastitis, so any kind of erythema, tenderness, maybe a low-grade fever. Staph aureus is usually to blame for that. It doesn't harm the baby, but we always want to encourage her, wash their hands before feeding the baby, completely empty the breast when feeding the baby, make sure they have a correct latch. If they're not able to empty by the baby feeding, then pumping afterwards, so again, make sure we have that breast empty. Engorgement usually resolves within about 24 to 36 hours, so if someone is not breastfeeding during that time period when the milk letdown is happening, we want to have them use cold compresses, a supportive bra, pain medications. It can be painful sometimes. Avoid any stimulation, no hot showers, things like that. Cabbage leaves too have been shown to be effective with that as well. With their cardiovascular system, again, you can see hemoglobin and hematocrit returns to normal about 8 weeks. They are still at risk for thromboembolism during that time. So again, we want to inspect their leg, look for signs of swelling, redness, tenderness, that could indicate that we have a DVT going on, because we don't want that to become a PE. It's actually one of the leading causes of maternal morbidity and mortality, so we want to try to recognize that. In the postpartum stage, we want to evaluate headaches, right? Headaches are going to require assessment. Is a headache because mom hasn't slept for 36 hours, she hasn't, been drinking water, and she's stressed out because the baby keeps fussing, right? Or does she have a headache because she had a spinal epidural? Does she have a headache because she was a preeclamptic patient and we could be worried about eclampsia? So again, just thinking about these things when we're taking care of our moms. Again, their joints should return in 6 to 8 weeks. They may still have the linea nigra, so that line that kind of runs up and down on their belly button. They may still have the mask of pregnancy. Sometimes that permanent darker pigmentation becomes permanent. They may experience stretch marks that on their breast or their abdomen or even their thighs. Sometimes they fade, but they don't disappear. And hair loss, it's weird, it's still hormonal, but sometimes you'll hear moms say it feels like all their hair is falling out of their head. Their immune system gets mildly suppressed and then comes back to the pre-pregnant state. So again, someone who has lupus or MS could kind of see a flare-up during that time period. So we want to make sure that we're educating them. All right, question for you here. The nurse will teach the client which postpartum signs to report. Select all that apply. Bright red bleeding, a temperature greater than 38 Celsius, chills, calf pain, inability to urinate, or excessive pain. We said all, you're right. All right, so it's all that above actually. So I know status normally aren't all, but again, those are things that we definitely want to be looking for. All right, when we think about, again, still in that postpartum time period, we're helping the moms, talking to them, educating them. If we have a mom like yesterday that had a cesarean section, they'll go to the recovery room afterward for 2 hours. They're never discharged from recovery, right? They just go there to kind of recover from the surgical procedure and the anesthesia. Discharge depends on how mom's doing, right? 24, 48 hours. We had one mom yesterday that was, what was it? She's Swahili, and she couldn't understand who had that one. You. And she wasn't understanding that she had to feed the baby more frequently than how much?
14 hours.
14 hours she went without feeding her baby. So they kept the baby another day to make sure mom understood, about feeding the baby, right? So C-sections will have a little bit longer stay. We want to make sure that we're teaching them peri-care. Again, looking at assessment of vitals. again, watching for postpartum hemorrhage. Security, so again, hugs tags on all the babies, ID band on baby matches ID band, those teddy bear bands on mom. It's a locked unit, right? All staff have IDs that they wear, again, trying to prevent infant abduction. We can have non-pharmacological interventions as well as pharm. So the patients may need tucks for comfort, they may need pain medications. There's even a spray called Dermoplast that helps them as well. We want to make sure we're getting them up and ambulating them to try to prevent that DVT. Again, they can't have any kind of abdominal exercises until about 4 to 6 weeks after a cesarean section. So they can't get out there right away. They can do little things though, they can walk and things like that. We want to have them, encourage them, if they are breastfeeding, continue with their prenatal vitamin, continue to have an increase of 500 calories per day, again, of breastfeeding to make sure that they have enough to feed the baby. Sometimes they may have incontinence, sometimes that's permanent, but things like laughing, coughing, sneezing, sometimes even lifting can have that happen. So again, encouraging those pelvic floor exercises after birth to try to help with that. Most hospitals have become what they call baby-friendly hospitals, so they don't give pacifiers routinely to the babies. Sometimes if parents bring it like from home themselves and have it, then that's okay for them to give it to their baby, but they no longer have them. So in 1991, the World Health Organization and the United Nations Children's Fund launched this baby-friendly hospital initiative and came up with 10 steps to try to encourage breastfeeding. So they have a written policy, they train all their staff on breastfeeding. They have to inform every single mom about the benefits of breastfeeding. They should initiate breastfeeding within 1 hour of birth. They have to show moms how to maintain lactation. Give the infants no other food or drink except for breast milk unless it's medically indicated. We want the babies rooming in, so no more sending the babies to the nursery, right? They stay with mom in the room. Encourage breastfeeding on demand, which I'm still like on the fence with that one because I think they need to eat every 3 hours from a pediatric standpoint, so I understand the demand thing, but when you got someone that waited 14 hours on demand, it's too long, right? Don't give any kind of pacifiers or artificial nipples, and then foster the establishment and support groups of breastfeeding. Moms will get rubella immunization if they aren't rubella immune. They can get varicella vaccination, again, if they're not immune. They can get the Tdap, and again, if they were Rh negative, they can get their Rhudan. Again, they should come and follow up with their provider, and then if the baby has a routine checkup as well, they'll go take the baby for their checkup. Initially, a client wanted to breastfeed, but now decided to formula feed their newborn. The nurse concludes teaching about breast care is effective when the client makes which statement. I'll pump 2 to 3 times a day until my milk supply decreases. I'll rub lotion on my breasts if they're sore. I'll soak them in warm water, or I'll wear a snug bra. All right. So what can happen is a complication in that postpartum time period, right? Postpartum hemorrhage. So one of the biggest things that I can say, and that's why I like to use this picture, is turn the patient on their side and look underneath them, because sometimes I had a midwife that taught me in one of my rotations, and she said that she had a patient one time that you went in and you wouldn't know she was bleeding. She went to turn her to change her pad, and her whole entire underneath of her was soaked with blood. So when we define postpartum hemorrhage, it's over 500 mLs of blood for a vaginal birth, or over 1,000 mLs of blood if they've had a cesarean birth, right? So we want to try to identify the cause of this, as well as try to prevent them from going into shock. So when we think of the causes, the 4 T's are always going to be the causes, right? So we think about tone, so uterine atony, right? A boggy uterus, if it's just kind of lazy and not clamping down, the blood's just gonna keep flowing, right? Tissue, so if they left a piece of placenta behind, that can cause a postpartum hemorrhage. Trauma, so any kind of laceration that may have occurred, we need to correct that, or if they have a rupture. And then the last T is, they say clotting, because the two T's in clotting, but a lot of times we know about that, especially if mom had a bleeding disorder before giving birth. So we always want to make sure that we look and identify, figure out what the cause is with this. Again, inversion of the uterus, so turning inside out, again, very rare. And subinvolution, so again, when we think about this, we don't want to do things like when the mom's having the baby, we don't want to be like tugging on the cord vigorously. We don't want to not guard when we're doing our fundal checks, things like that to prevent this. If someone is experiencing postpartum hemorrhage, again, just like if somebody didn't have a heartbeat, right, the first thing you would do is your compressions on the chest, right? So the same thing is going to be this for postpartum hemorrhage treatment, right? If someone's bleeding, the first thing you're going to do is start doing fundal massage. And that's why you try to figure out your 4 T's, right? So you're going to go through and try to figure out what's going on. Again, when we want to look at this, we want to try to minimize the amount of blood loss that we have. If we have someone that does go into hypovolemic shock, again, we may need to give packed red blood cells or fresh frozen plasma, something like that to try to help, even platelets to try to help. We're looking at mom's skin, again, looking for petechiae or purpura, again, during that postpartum time period, trying to identify if we have DIC or not. Again, looking at the lower leg, as I mentioned before, and you'll still see some nurses do it, and I'm like, stop doing this, but they used to do Holman's, right? So they used to do Holman's sign to see if there was pain in the calf. If they did that, and that usually kind of like said, oh, they could have this DVT, right? But what they found is when they were doing Holman's, that a lot of times they were dislodging the clot, and it was becoming a PE, so they said, don't do this anymore, right? But it's like 1 in 1,000 pregnancies that they could have an embolism. So we don't want to do this. We encourage them to get up moving as soon as possible to try to prevent this, right? So we're looking at signs of like swelling, like I said, swelling, redness, tenderness on there. Other risk factors would be like if they were a smoker or advanced maternal age or obese. Looking at postpartum infections, again, could be a number of things, mastitis or endometriitis. Again, looking at that fever over 38 in order to identify infection there. Again, prevention is key, so encouraging good hand washing, good hygiene, and education before they get discharged. So we look at mood disorders, right, because postpartum depression is often has a number of different risk factors associated with it. As many as 20% of women will experience some sort of postpartum depression. So again, we need to identify those that had a pre-pregnancy mood disorder in order to identify those at risk. So we look things like not naming the baby, not interacting with the baby. Like I mentioned before, we had one patient at Barberton that every time the students went in, the mom would be like, can you feed the baby? Can you change the baby? And the students were all excited, right? Because you guys love to do that. But mom really wasn't interacting with her own child. So a lot of times when we talk to them about postpartum depression or even baby blues, right? Like, so baby blues, like it says 85% of women can experience baby blues, right? So when you're giving this education as the nurse, you're telling the patient, but a lot of times they'll also turn and look to the partner in the room too and say, these are the signs that you're gonna look for. This is what you wanna see, right? Because again, we wanna see if they're not taking care of the baby, if they're sleeping all the time or not sleeping at all, right? If they're crying and things like that. So I'm gonna